Hello, everyone. My name is Gaurav Singh, and I'm a Mohs surgeon and dermatologist at City of Hope Cancer Center, Chicago. I'm excited to talk to you about my session at AED, which is titled Beyond the Surgery, Advances in Cutaneous SCC, Squamous Cell Carcinoma Risk Stratification. I'm excited to talk to you about this topic because this is a condition that affects thousands of people every single year. The epidemiology shows that about 15,000 people per year die from cutaneous squamous cell carcinoma. Unfortunately, there's likely something that could have been done differently for a lot of these patients, and that's where a lot of my clinical and research interests lie. For example, patients can have a stage 1 tumor, and we'll talk about that and what that means in just a moment, that actually may go on to have a bad outcome. And the example that I always like to give when I speak to other Mohs surgeons, dermatologists, oncologists, and radiation oncologists, and people in the community, is if you would imagine a transplant patient coming into your office with a 1.8 centimeter tumor that's moderately differentiated on the ear, by traditional staging systems, this would be considered a low risk or a low stage tumor. But we likely know that based on some of those clinical and patient features, that's not truly the case. And so the purpose of this session is to highlight some tools that exist in addition to traditional clinical pathologic staging, where we could accurately stratify patients into the correct risk and have actionable outcomes based on those features. There's a study in the JAD that talked about some of these risk features published in 2024. And some of those risk features include tumors between 1 and 2 centimeters, tumors on the head and neck, tumors that are moderately differentiated, and tumors with small caliber perineural invasion. And this is in contrast to some of the staging risk factors that many of us use on a daily basis to accurately stratify patients. Those staging risk factors include size over 2 centimeters, invasion beyond the subcutaneous fat, perineural invasion of at least 0.1 millimeters of the nerve and greater, and of course, poor differentiation. However, as we know, there's a lot of subjectivity into what is considered poor differentiation. And for example, what one person and board-certified dermatopathologist or Mohs surgeon may consider to be poorly differentiated could easily be called moderately differentiated by someone else. The reason this is so important and the reason this matters for clinical outcomes is because when we look at ASTRO guidelines on when radiation after surgery, i.e. adjuvant radiation, is indicated, large caliber PNI, perineural invasion, and poor differentiation are both risk factors that would lead us to consider radiation in many of our patients. One of the tools that exists to help us includes gene expression profiling. Specifically, DecisionDx-SCC or DecisionDx squamous cell carcinoma. What's unique about DecisionDx-SCC is that it's objective and agnostic to some of these clinical pathologic features that we are already used to. I use DecisionDx-SCC in my practice to both escalate and sometimes de-escalate care where appropriate. For example, in the case of escalation, if I have a patient that meets certain criteria, for example, a large tumor on the head and neck, tumors invading beyond the fat, tumors that are moderately differentiated, I will often use DecisionDx to decide if that patient may benefit from adjuvant radiation. DecisionDx results come in different flavors or varieties, and a class 1 result is thought to be low risk, and a class 2B result is the highest risk. And there are some intermediate results that are typically considered to be higher risk. When I receive a class 2B result on a low stage patient, there is enough evidence with several papers, including with Dr. Ruiz and Dr. Aaron, that actually lead us to believe that these patients may benefit from radiation. In my clinical experience of seeing thousands of patients with these high-risk cutaneous squamous cell carcinomas, a large portion of those class 2B genomic tumors are actually traditionally low-stage tumors. So these are likely comprising at least a fraction of the patients who currently pass away from squamous cell carcinoma and otherwise don't meet criteria for radiation. So a critical focus of this session was actually identifying which low-risk tumors by traditional factors actually are higher risk than they may appear. The other flip side that I see a lot in my practice includes patients with very large tumors that often go beyond the subcutaneous fat after Mohs surgery. I see patients from all 50 states in my practice, and patients who often have large tumors would not want to have many sessions of adjuvant radiation. What we often do for these patients is include their gene expression profile risk in our decision making. And sometimes in the appropriate setting, if a patient has a low gene expression profile risk, we will forego radiation in the appropriate clinical context. And of course, this type of de-escalation in care can sometimes be unnerving to a lot of people, and we do shared decision making with patients. DecisionDx-SCC often also allows us to give exact prognostic information that's available to us as clinicians and, of course, to the patient. So there are lots of things that we can do differently with that information in store. For example, if a patient comes back with a class 2A result with a high stage, we may often do imaging, i.e. a nodal ultrasound every 3 months. Or if ultrasonography is not locally available, we may consider CT scans about every 6 months for up to 2 years in the right clinical context. And the purpose of this closer imaging and closer serial monitoring is because if we have a patient with a metastatic outcome and we are able to catch that metastasis before the patient is symptomatic, we know that survival is significantly higher. So prognostic tools like DecisionDx-SCC are critical in making sure that patients get appropriate risk stratified care. I think there are lots of directions the field is headed in the future as well, and that includes the utility of immunotherapy. The FDA has approved several immunotherapy options for our patients, including cosibelimab and cemiplimab, and the session also focused on the utility of these medications for advanced cutaneous squamous cell carcinoma. In our clinical practice, in addition to using the approved on-label indication, in the right clinical practice, we do also consider using neoadjuvant immunotherapy as well. So we will often use neoadjuvant cemiplimab to shrink the tumor ahead of time before we perform definitive surgery on these patients. Sometimes, if the patient has a high genetic profile risk or meets high-risk features in their NCCN criteria or the iRisk calculator, we may, in certain cases, be more likely to use neoadjuvant immunotherapy in the right clinical context. We also like to use tools that help monitoring of these tumors, and one of the tools we like to use is circulating tumor DNA. Squamous cell carcinoma is not always shedding as much DNA as some other malignancies, such as Merkel cell carcinoma or bladder cell cancer. However, sometimes the first sign of disease spreading to the lymph nodes or even recurring locally can be that the patient's circulating tumor DNA starts to go up. Circulating tumor DNA is a blood test that's developed based on the individual patient's tumor, and there are different utilities for the overall test, and a lot of information is added from the blood test alone. When the circulating tumor DNA levels go up and stay up, that is often a sign of recurrent disease, and that recurrence can sometimes be local, nodal, or even metastatic. We will sometimes use immunotherapy after the patient has an increase in their circulating tumor DNA level. One of the directions the field is likely headed is to answer the question of whether or not we should be treating on molecular recurrence. And what that means is if a patient has no clinical evidence of disease, but their circulating tumor DNA levels start to go up, should we be starting treatment such as immunotherapy on that patient before we have clinical signs or symptoms of disease? There's a lot more data that needs to be done in respect to that, but I look forward to seeing where all of that is headed. In summary, I appreciate you joining and you're interested in learning more about how we can best take care of patients with cutaneous squamous cell carcinoma. Multidisciplinary care is important, and we often work with our medical oncologists, radiation oncologists, surgical oncologists, Mohs surgeons, and of course, primarily the patient to decide the best steps for that individual patient's treatment. We use NCCN guidelines, we use risk stratification tools, including iRisk, and to have the best possible prognostic tool that's individualized to the patient and their tumor, we like to use DecisionDx squamous cell carcinoma, which is gene expression profiling. Allowing us to use all of these tools makes sure that the patients have the best possible outcome that we can give them. And that oftentimes includes surgery, radiation, and/or immunotherapy in any given order. So what that means is sometimes patients have immunotherapy prior to their surgery, and then they may have radiation afterwards. Circulating tumor DNA is an up-and-coming tool in the world of cutaneous squamous cell carcinoma, and it will be interesting to see where that goes. I look forward to hearing your thoughts in the discussion.